I want to talk a little bit about spinal cord injuries, at least the first 72 hours of care of patients with spinal cord injuries. This is part of the Concepts in Trauma Care series that's put on by MedEd Productions. When we look at the actual epidemiology or the occurrence of spinal cord injuries, you can see some of the statistics listed on your screen. There's about 10,000 new cases of spinal cord injury every year. And that means that if we look at how does that impact our society, somewhere between 183,000 and 230,000 Americans are alive today with spinal cord injuries. And sadly, as you can figure out, these patients have significant challenges in life because of the devastating effects that spinal cord injury has on functioning of the patient. The average age of spinal cord injury is 31.7 years, and I'm going to say that's a sad statistic. Now, I don't want to decrease quality of life at any age, but what spinal cord injury does is it robs our youth because it happens in young people so much more than other injuries. The greatest frequency of injuries, in fact, is between the ages of 15 and 25 years of age. Males are more likely to sustain spinal cord injuries than females, and this really comes down to the fact that overall, not absolutely, but overall, males tend to undertake high-risk activities more than females, which accounts for the reason that males have a little higher, or quite a higher rate actually, of spinal cord injury. Now, if we actually look at what causes spinal cord injury, you can see some of the more common causes on the screen. Motor vehicle collisions remains one of the main causes of spinal cord injuries, but other things include falls. They account for 17 to 21%. Recreational activities accounts for 17 to 21%, and violence from somewhere between 5 to 29%. So these are some of your causes of spinal cord injury. Now, in order to be able to lay down the foundation for the rest of this lecture, I want to discuss for a little bit spinal cord anatomy. Your spinal cord is a very specialized set of nervous tissues. In the front of your spinal cord, or the anterior portion of the cord, is where you'll find your descending motor neurons. So the motor neurons that go from the brain down to the body and tell your body what to do. When I wave, that's a motor function. That message starts in the brain, goes down the front of my spinal cord, and tells my body to wave. So the anterior cord is where you'll find your descending motor neurons. Now, the back of your spinal cord, the posterior section, is your ascending sensory neurons. So when sensory perceptions are picked up from the environment, they go up the spinal cord to the brain through the back. Specifically, light touch, proprioception, and vibration go up the back of the spinal cord. And if you've forgotten what proprioception is, by the way, proprioception is the ability to know how one body part is in relation to another. So if my eyes are closed, I know that my hand is up only because I have proprioception. Otherwise, I wouldn't know where it was at. And you'll find that proprioception is carried up to the body through the posterior section of the spinal cord. Now, your lateral cord, you have these lateral tracts over here. They carry ascending sensory motor neurons as well, but there, pain, temperature, and crude touch are carried. Okay? One other thing I want to cover when it comes to spinal cord anatomy before we get into actual injury is to talk about crossover points. As you may recall, one side of your brain runs the other side of your body, and that's because your nerves cross over. And they cross over in different parts of the spinal cord depending on what we're talking about. If your anterior cord, now remember your anterior cord is the one that has descending motor neurons, they cross over right at the base of the brain as it enters the spinal cord. So when I wave, that message actually starts on this side of my brain, comes down, and then when it gets to the spinal cord, it crosses over and goes down the opposite side of the spinal cord from where it initiated. So it crosses over right at the base of the brain. The same can be said for your posterior cord. We said that light touch was part of the posterior cord. So if I touch my suit jacket, it can tell it's a textured jacket because I have light touch. That message goes up the spinal cord in the back on the same side as the touch, and then it crosses over at the base of the brain where it's interpreted as texture on the opposite side of the brain. So the anterior and posterior cord cross over at the top of the spinal cord, but your lateral cord crosses over where it enters into the spinal cord. So we know that one thing that was influenced by, or was carried, I should say, by the lateral cord is temperature. So in front of me right now, even though you can't see it, is a table. If I put my hands on the table, it's colder than the environment. So that message goes up the side of the cord. However, that cold message goes up, crosses over at the place where it enters the spinal cord and goes up the opposite side. So my lateral tracts cross over quite low, whereas my anterior and posterior tracts crossed over at the top of the spinal cord. The lateral tracts cross over where they enter the spinal cord. Now I'm going to guess most of you are saying, does that really matter? Well, in a way it will. In just a few slides I'm going to make all of that matter, so hold on to that thought. We can divide spinal cord injuries into primary and secondary injuries. A primary injury is an injury that occurs at the time of the incident, when it actually happens. If you have, for example, a fractured vertebrae and the wedge of bone wedges into the spinal cord and cuts some of it, that's a primary injury. The fracture happened at the time, and then the laceration of the spinal cord occurred at the time. That's a primary injury. It's done. It's happened. It can't be changed. We can't influence it. We have to work around the primary injury. Let's say the vertebrae slide off of one another and they cut the spinal cord where they slide. That cut is a primary injury. It occurred at the time of the incident and it can't be changed. It's done. That's your primary injury. So remember, your spinal cord is contained within your vertebral column, and on your screen you can see that I kind of put a little gray area inside of the vertebral column. That's your spinal cord, and it's protected by the bony prominence. But if the bones slide off of one another, if the bones are fractured, they can impinge on that spinal cord and cause your primary injury. You know, and on the screen I've shown a few radiographic imaging studies of primary injuries. You know, you can see in the x-ray an obvious subluxation of the vertebrae, and we have to assume that the spinal cord is pinched in that subluxation, and whatever of the spinal cord is cut or injured from that subluxation, it's done. It's occurred. In the MRI, on the other side, you can see how the spinal cord is pinched inside the vertebrae. That pinching has caused damage. It's done. It can't be changed. That's the primary injury. Now, secondary injuries occur afterwards. They don't occur at the time of the injury, but they evolve afterwards. Some of this can be due to edema. Your spinal cord is living tissue. You injure it, it's going to swell. And that swelling inside of a vertebral column is going to lead to secondary damage to the spinal cord. On the screen in front of you right now, you can see I've put not only the spinal cord inside the vertebral column, but I've also drawn 4 little red circles. Those are meant to represent blood vessels. We have blood vessels that come over the top of C1. They leave the aortic arch, they come over the top of C1, and they go all the way down the spinal column, giving oxygen to the spinal cord as it goes down. So think about what happens if you have a spinal cord injury where, let's say that the vertebrae sublux, they move, and the spinal cord is pinched in between and it begins to swell. Well, as it swells inside the vertebral column, guess what's going to happen to those arteries around the spinal cord, those little red dots? They're going to become compressed. And now not only do you have the primary damage, but now you have a pinching of those blood vessels as they go down the spinal cord, and that's going to lead to hypoxia below it, and that's going to evolve afterwards, which is why we call it a secondary injury, because it occurs or it evolves after this primary injury, mainly due to edema and some of the oxygen-free radicals and so on that occur with tissue injury. So this is your secondary injury. So hypoperfusion slows or blocks propagation of action potentials along axons, leading to spinal shock. Then you get your oxygen-free radicals, leading to edema. Edema leads to compression of the blood vessels, and that leads to hypoxia. Now, what really differs primary from secondary injury is primary injury occurs and it usually can't be altered. It's done, the injury is done. Secondary injury evolves in the minutes to hours after the injury, and we can influence this to a certain degree. We can minimize secondary injury by certain interventions that we will talk about. So it's important from a healthcare standpoint that we focus on secondary injury. Now let's start by talking about a complete cord injury. What's a complete cord injury? Well, think about the name and you'll figure it out. It's where the cord is completely injured. I mean, there is no communication above and below the level of the injury. If you have a subluxation where the vertebrae slide off of one another and the spinal cord is torn, that is a complete cord injury. And there'll never be communication above and below the level of the injury ever again. It's completely injured, gone, torn. The patient will have no sensory or motor movement or sensation above and below the level of the injury. That's a complete cord injury. Now on the screen, I've given you a table which goes over the deficits associated with a spinal cord injury at the various levels that the spinal cord is injured. How we name spinal cord injuries is we name them for the level at which the patient still has function. So let's say you're caring for a patient with a C6 spinal cord injury. Slide across on that chart and you'll notice that C6 allows flexion of the elbow. So if a patient has a C6 injury, guess what? They can still flex the elbow because you still have function at the level at which the injury exists. So a patient with a C6 will be able to flex their elbow and everything above it, including shrugging of the shoulders and spontaneous breathing. However, they will lose everything from the level of the injury down. So because C7 is extension of the elbow, that will be lost, as will flexion of the fingers and so on as you move down the chart. So the injury is named for the level that function still exists, and you'll be able to do everything at the level of the injury and above it, but you'll lose everything below the level of the injury. So this chart can just help you anticipate the deficits associated with the various levels of injury in spinal cord trauma. Did you know, though, that about 95% of spinal cord injuries are not complete? They are partial. A partial cord injury is where part of the cord is injured, but part of it still transmits impulses. And if you look at that drawing on your screen, you'll notice that there's a fracture of the vertebrae, and that fractured bone has impinged in on the spinal cord, and the part of the impingement of the bone will lead to a deficit. So the patient will have deficits, but part of the spinal cord is not affected. So the patient will still have transmission of impulses in the unaffected part of the spinal cord. That makes this a partial cord injury. And the majority of spinal cord injuries are partial, where a patient has at least some degree of either movement or sensation below the level of the injury afterwards, because some of the spinal cord is maintained or sustained. We actually name these spinal cord injuries, and I want to look at some of the more common partial cord injuries. Now, in an anterior cord injury, we'll think about the name. An anterior cord injury is where you injure the anterior portion of the cord. This is usually from a forward movement of the head being thrown violently forward, and when the head folds downwards, the vertebrae fold in or impinge on themselves, and they damage the front of the spinal cord. That's why we call it an anterior cord injury. Now think about this. What's carried down the front of your spinal cord? We said it earlier, your descending motor neurons. So if you injure the front of your spinal cord, you will lose your motor function and you'll be paralyzed. However, the back of the spinal cord may be maintained. So you may have some degree of sensation, especially light touch, proprioception, and vibration will be maintained. Now the lateral cord, which carries pain, temperature, and crude touch, may be affected. It may not be affected. It depends upon how far back the injury goes. So those may or may not be present. So sometimes to simplify an anterior cord injury, we say that the patient can feel, but they can't move. That would be an anterior cord syndrome. This is actually the most common of all of the partial cord syndromes, is an anterior cord where the head is thrown violently forward. The patient can't move, but they have some degree of sensation afterwards. Now, a posterior cord syndrome would be the opposite, right? Where the head is thrown violently backwards, so the vertebrae impinge in on the back of the spinal cord and lead to loss of the functions of the back of the spinal cord. And what happens in the back of your spinal cord? Well, your ascending sensory neurons for light, touch, proprioception, and vibration are found back there, so they'll be lost. So if I tried to simplify a posterior cord syndrome, these patients can still move because the anterior cord is intact, but they've lost their ability to feel. This is a very uncommon spinal cord injury. It's rarely ever seen. Now let's get to some weirder spinal cord injuries. How about a central cord syndrome? The name tells you what's happening. The center of the cord is more injured than the outside of the cord. This usually has to do with the subluxation of the vertebrae, where the vertebrae slide off themselves, and when they slide, the spinal cord is squeezed or squished, and the inside of the cord may have more damage than the outside. Now, our arms are innervated from the middle of the cord, your legs from the outside of the cord. So a patient with a central cord syndrome will have more damage to the middle of the cord where the arms are innervated. Therefore, we'd expect the patient to have greater deficits in the upper body and less deficits in the lower body. So patients with anterior cord syndromes often lose the ability to move and even feel their upper extremities and chest, but are able to move and feel their lower body. On the picture on your screen, you can see in gray the areas of deficits in an anterior cord syndrome, and the area in white would be the unaffected areas. There's a mnemonic that's sometimes used to help you remember this, that patients with central cord syndromes can dance, but they can't play the piano, because they can move their legs, of course, but they can't move their arms. This is not an uncommon syndrome by any stretch of the imagination. It's more common in the elderly because of osteoporosis and some of the changes in the vertebral column, but it can occur at any age. One of the weirdest of the partial cord syndromes is on the next slide, and that is Brown-Séquard. Brown-Séquard syndrome is where you have a lateral injury to the spinal cord, usually a gunshot, stabbing, or other penetrating trauma like you see pictured on the screen. And because the spinal cord is cut laterally, you're going to have only loss of movement and sensation to half the body. However, this is why I talked about crossover points. Because anterior and posterior spinal cord crosses over at the base of the brain, and because the lateral cord crosses over at the entry point, what we may see is that because the spinal cord is cut in half, that the deficits associated with the anterior posterior cord, which cross over above the injury, will affect this side of the body, but the effects of the lateral cord, which may cross over below the injury, will affect this side of the body. So a patient with Brown-Séquard syndrome may be able to move one side of the body, but they can't feel it. They won't be able to move the other side of the body, but they can still feel the side they can't move. I told you that one was weird, right? You move one side, don't feel it. You can't move the other side, but you can feel it. That's Brown-Séquard. Now, Cauda equine syndrome occurs when usually you fall on your butt. And at the very base of your spinal cord, and I've kind of outlined it with a red circle in that drawing on your screen, you have this area of the spinal cord that fans out like a horse's tail. This is why it's called a Cauda equine syndrome, the equine being horse, of course. And the nerves that come out from the base of the spinal cord innervate the inside of the thighs, the genitalia, the bowel, and the bladder. So people who injure this part of their spinal cord may have weakness to the inner thighs, the upper legs, they may lose bowel control, bladder control, and they may also have sexual dysfunction as well. There's varying degrees of this. Some of these patients will end up wheelchair bound because they lack the strength to hold up their own body with the weakness in their legs. Others may have a fairly normal life in regards to at least ambulation if they can hold themselves up, although they may have to make alternate arrangements for bowel and bladder, including intermittent catheterization and enemas and so on. So you can see varying degrees of Cauda equine. So what I want to do now that you kind of have a basic pathophysiology of spinal cord injuries is let's talk about how to assess the patient who has a known or suspected spinal cord injury. What are some general signs that a patient has a spinal cord injury? Well, they'll often have an abnormal breathing pattern, although that'll be influenced by where the injury is. The higher the injury is, the more altered their breathing pattern will be. Somebody who has an injury at C6, they won't breathe because, somebody has an injury at C4, that's my apology. Someone with an injury at C4 won't breathe because they've lost their diaphragm, they've lost their intercostals, they've lost their accessories. They have no ability to breathe. Without assistance, they will never breathe. Now, you get down to, for example, T3, T4, an injury down there, those patients still have accessories and diaphragm muscles, so they'll have breathing. They'll even have some intercostal muscles, at least above T3, so there'll be some chest movement, but the area below T3 will have no intercostals with decreased chest movement. So when you're assessing the patient with spinal cord injury, you may see some odd breathing patterns. Purely diaphragmatic breathing without any accessory muscle or intercostal muscle use. You may see movement of part of the chest above the level of paralysis with no movement below. So you're looking for some weird abnormal respiratory patterns. The patient may have Horner's syndrome, which occurs especially with higher spinal cord injuries where they have unilateral ptosis or drooping of an eyelid, unilateral miosis or constriction of the pupil, and unilateral anhidrosis, which would be sweating but only to one side of the body. Those could be indications of a spinal cord injury. A priapism may occur. This is more common in males. Yes, that was a joke. But yeah, priapism may occur. This has to do with neurogenic shock and vasodilation of the blood vessels of the penis. The male with a traumatic injury may come in with an erection or a priapism. And this is a fairly certain finding of spinal cord injury. Patients may also experience pain along the level of the injury. So for example, a patient with a spinal cord injury in the high C spines may complain of occipital pain. Patients with injuries, on one of the T spines may experience pain right along the intercostal muscle at the level of the injury. So they may have this odd pain at a certain part of their body, and then of course loss of pain below that level. So those are some signs to look for spinal cord injury. If you suspect somebody's got a spinal cord injury, palpate their spine, looking for tenderness, looking for obvious deformity, maybe soft spots or step-offs where the vertebrae are no longer in alignment. Look for tight muscle spasms or a widening of the space between the between the vertebrae along the vertebral column. So you just want to palpate down the spinal cord looking for any of those abnormalities. You'll want to do an assessment for sensory function. Does the patient have sensation? Even if they have a known spinal cord injury, you want to assess for a complete versus a partial cord syndrome, and sensation would help to differentiate between these two. You're looking for areas of decreased sensation. Now, it's always best to start from areas that you know have decreased sensation and move towards areas that you suspect still have sensation, because patients are more sensitive to the appearance of pain than the disappearance of it. So, if somebody's got a spinal cord injury that causes numbness, we'll say from this level down, and you start testing for pain or for touch above the injury and then move down to the part that's numb, the patient may have a decreased ability to know when the pain disappears. However, if you start below the injury and move up, the patient will be able to very easily verbalize when they start feeling the sensation. So move from areas of decreased sensation to areas of increased sensation and see what level that occurs for. Now, if you're looking for posterior cord involvement, you might want to use a cotton wisp and move the wisp along the areas because, of course, light touch is affected by posterior cord syndromes. Where if you're looking to test your anterior or lateral cord syndromes, you would want to induce pain. And a good way to do that would be like a needle or something similar, because pain is carried in the lateral tracts. So posterior tracts, light touch, use cotton. Lateral and anterior tracts carry pain, and you'd want to use a pen or something else that causes pain. Now, this chart is not new to any of you, I'm sure. It shows you the various dermatones of the spinal cord as they exit out of the vertebral column, and where the numbness would be expected. So you can kind of, if you use this chart and you know where the patient's loss of sensation starts, you can kind of figure out where the injury is by comparing it to this chart. And I'll leave that chart for you to look at on your own time. A few important notes about patient assessment. Islands of sparing may occur where you have loss of sensation at a certain level, but you notice that the patient does have some degree of sensation in various places below that level, kind of like islands of sparing, as the name implies. This may be a positive thing for the patient because it could indicate that the patient has at least a partial cord injury at the worst case scenario, or maybe spinal shock in the best case scenario, but that the spinal cord is not completely injured. So you want to do a good assessment of the entire body below the level of the injury to determine if there is any islands of sparing or areas where sensation may be maintained below the level of the injury. It's a positive sign to a certain degree. You'll also want to do a careful assessment of where loss of sensation starts on the patient during your assessment, and then continuously assess the patient after that, looking for cephalid progression of hypoesthesia, or in other words, upward movement of loss of sensation. Because as the swelling occurs inside the vertebral column, the swelling can cause pinching of those blood vessels higher and higher, which is going to lead to loss of sensation higher and higher in the hours and days following the injury. So knowing where the patient and marking where the patient's hypoesthesia starts and then continuously assessing will help you to determine if secondary injury is occurring and if the deficits are moving upwards. You'll also want to assess for sacral sparing when you're assessing patients with spinal cord injuries, looking for sensation around the anus, for presence of sphincter toe, and for the ability to flex the great toe. The nerve that runs these functions is right in the middle of the spinal cord, like smack dab in the middle. And so sometimes if there is injury to the cord or the cord is pinched, that middle may be protected, and then you have sacral sparing, or sparing of the rectal sphincter tone and the flexure of the great toe. And this may be a positive sign for the patient because it indicates that at least the spinal cord is intact and that there is at least some sensation and movement going down the middle of it. It doesn't always mean it's going to turn out good, but at least we know that there's some sparing of that center part of the cord. So look for sacral sparing. Now, you'll want to assess for patient reflexes below the level of the injury. If a patient is paralyzed but has intact deep tendon reflexes, then we know the injury is an upper motor neuron lesion. Whereas if the patient is paralyzed and has no deep tendon reflexes, we know it's a lower motor neuron lesions. And overall, absent reflexes indicate the possibility that there may be some resolution, especially with surgical intervention. So it's important to assess for the presence or absence of reflexes below the level of the injury. All right, so those are a few notes about patient assessment. Now let's talk about some treatment considerations when you're caring for the patient with a known or suspected spinal cord injury. These recommendations that I'm about to give you come out of the Consortium for Spinal Cord Medicine, which was released a few years ago. It was a consortium put together by the Veterans Administration of some of the leading experts in spinal cord injuries who looked at current research and came up with recommendations for caring for the spinal cord injured patient. So these are the recommendations that come from that consortium. The first ones are listed on your screen. Patients with spinal cord injuries should be enrolled in the trauma system as soon as possible and transferred to a level 1 trauma center as soon as feasible. Spinal cord injuries require specialized care. They require specialized care in the acute phase and the rehabilitation phase. And it's important that the patient gets to a center that can provide that care. Now, not all trauma centers can provide spinal cord trauma care. In fact, a lot cannot. However, trauma centers are trained in the care of the trauma patient, including protection of the C-spine. So we want patients moved to trauma centers who have a risk factor for spinal cord injury to increase the protection of the spinal cord. And then if a spinal cord injury is recognized or confirmed, then the patient needs to go to a facility who specializes in trauma care, spinal cord care, because of the special needs these patients will have. Immobilization of the spine for any patient who has a mechanism of injury that could cause a spinal cord injury or any signs of deficits is recommended. In fact, it's the standard of care to immobilize the spine of any patient with a high risk of spinal cord injury due to mechanism or any signs of spinal cord injury. Look at the statistic that I just flashed up on your screen right now. It should bother any of you who are involved in care of the trauma patient. It has been estimated that as many as 25% of spinal cord injuries occur after the initial insult, either in transit or during early management of patients with spinal cord injuries. What is that statistic saying? 1 in 4 people who have paralysis may have developed that paralysis not from the initial incident, but from our handling afterwards. And that's a really sad statistic, which really is saying that we all need to recognize the importance of proper spinal immobilization, undertake it in high-risk patients, use caution when working with these patients until spinal cord injuries can either be ruled out or cared for. Now, when you're transporting the patient who either has a spinal cord injury or is at high risk for one, spinal immobilization should include a rigid cervical collar, supportive head blocks, and a backboard with straps or some similar device to that. And those are the recommendations from the Consortium for Spinal Cord Medicine. One thing I think that's important to take is the statistic I just flashed on your screen, that as many as 20% or 1 in 5 spinal cord injuries involve non-contiguous vertebral levels. So what does that mean? If a patient has, for example, a spinal cord injury at C5, there is a chance, a 1 in 5 chance, that they may have other injuries in other vertebrae that are not close to C5, maybe T4 and T10. So the importance of immobilizing the entire spinal cord is important because 1 in 5 will have multiple areas of vertebral injury. Okay, let's talk about the ABCs of trauma care now. And again, these come from the Consortium for Spinal Cord Medicine. Airway is an important component in any trauma patient, including the patient with spinal cord injury. Because these patients may have difficulty clearing their own airway, they may have lost the ability to cough, they may have lost the ability to turn their head, especially if we've immobilized them. In the case of secretions or vomitus, their airway is vulnerable, and they're very vulnerable to airway obstruction. So consider the need for suctioning. You may have to give the patient a suction wand. You may need to even consider definitive airway control, including intubation during the acute phase. Overall, any patient with an injury above the level of C5 will require intubation because they've lost their accessories, they've lost their intercostals, they've lost their diaphragm. They've lost any ability to ventilate themselves. They're going to require intubation and mechanical support, probably for life, but certainly during the acute phase. Now, the chart that's on your screen right now goes over the deficits of both breathing and airway based on the level of injury. A patient with an injury at C1 to C2 has 5 to 10% of their normal vital capacity. So needless to say, their breathing is inadequate and will require mechanical ventilation. They also can't cough. They have no way to clear their own airway, and they'll need to have their airway protected. Now, between C3 and C6, a patient has 20% of normal vital capacity. That is inadequate to support life, and those patients will need to be intubated. They do have a cough, however, it's weak and ineffective, and they will also require complete airway protection. From T2 to T4, a patient has 30 to 50% of their normal vital capacity, which is usually enough to sustain life. And these patients may not need to be intubated or need mechanical ventilation. However, remember that injuries move upwards as edema worsens. So a patient who may be breathing on arrival may have respiratory difficulty in the hours that follow and will need careful assessment. From between T2 to T4, the patient has a weak cough. They may be able to protect their airway from major insults, or from minor insults, but major insults such as vomiting will require support such as suctioning. Now, once you get below T5, both vital capacity and the cough remains unaffected, and these patients can usually protect their own airway and breathe unassisted. As far as breathing interventions go, intubation is always indicated for any injury above C5, but remember injuries below that, say C6 and C7, may breathe on their own on arrival, but may require intubation in the hours that follow if edema moves up in a cephalid matter. Propofol and thiopentol can exacerbate the hypotension frequently associated with spinal cord injuries, therefore they are not recommended. Ketamine, etomidate, or other induction agents for intubation that don't cause hypotension should be used. Ideally, a patient should have their degree of breathing deficits measured on arrival. In other words, their vital capacity should be measured when they arrive. Typically, respiratory therapists will do this in most hospitals, and if we can measure a patient's tidal volume, vital capacity, and negative inspiratory force early in their care, it gives us a baseline, and then as the patient progresses through rehabilitation, we can determine whether or not the injury is worsening or whether they're maintaining those baselines. So if at all possible, we want to get RT to come measure the baseline breathing functions on these patients. Let's move on to circulation now. And for circulation, one of the things we worry about is neurogenic shock. And in order to cover neurogenic shock, I'm going to do a quick review of the sympathetic and parasympathetic nervous system. Now, you may have gotten this review if you've watched other modules in this series, so I don't want to duplicate myself, but since I don't know what order you're going to watch them in, I'm going to give you a very brief reintroduction to the sympathetic and parasympathetic nervous system. Most of you know about these anyway. The sympathetic nervous system is your fight or flight response. It is what allows things such as vasoconstriction, increased heart rate, increased respiratory rate associated with stress, with the fight or flight response. Your sympathetic nervous system is actually housed in your brain, and it travels down your spinal cord where it exits out and causes the various changes in the body, such as vasoconstriction and increased heart rate. Now remember, your sympathetic nervous system has an opposer. It's the parasympathetic nervous system. It reverses or changes any of the things that are made by the sympathetic. So if the sympathetic causes an increased heart rate, the parasympathetic will cause a decreased heart rate. Basically, the idea of the parasympathetic is to allow the body to return to its normal state after a sympathetic response. Now, your parasympathetic nervous system doesn't travel through your spinal cord. It travels down the vagus nerve where it causes the various effects in the body, such as vasodilation, decreased heart rate, and decreased respiratory rate. So what is neurogenic shock about? Neurogenic shock is all about the loss of that sympathetic tone. Because your sympathetic nervous fibers go from the brain down the spinal cord and out to the body, if you have a spinal cord injury, your brain has no way to communicate with your body, at least not sympathetically. And so all sympathetic stimulation from the level of the injury down is lost. The patient loses the ability to vasoconstrict. The patient loses the ability to elevate their heart rate if the injury is high enough, and all the other changes associated with the adrenergic or sympathetic nervous system. However, because your vagus nerve is not contained in the spinal cord, it's found, in the neck, a spinal cord injury won't affect that. And so the vagus nerve will continue to function leading to parasympathetic stimulation. And so basically a patient with a spinal cord injury has no sympathetic stimulation because their sympathetic fibers are lost with the injury, but they still have parasympathetic stimulation via the vagus nerve, and that leads to what's known as neurogenic shock, a vasodilatory shock that's caused by loss of sympathetic tone. Let's look at this a little more closely. Remember, your sympathetic nervous system, when it is stimulated, it stimulates your alpha receptors throughout your body. Alpha receptors, when stimulated by the sympathetic nervous system, cause changes such as vasoconstriction, the release of glucocorticoids from the adrenal glands, which in turn stimulates glucogenolysis. That's the breakdown of glycogen into glucose, releasing it into the bloodstream. So glucose levels go up with sympathetic alpha stimulation, and this is meant to augment the fight or flight response. And also alpha stimulation causes the skin to become sweaty. This is your body preparing for the fight or flight. If I'm going running, I'm going to generate heat, and I'm also going to need energy. So the glucogenolysis, or the breakdown of glycogen into glucose in the liver, is going to elevate blood sugar levels to give me energy for the run. And because running generates heat, diaphoresis prophylactically gets rid of heat. So a patient with alpha stimulation will have vasoconstriction, elevated blood sugars, and sweaty skin. But remember, in neurogenic shock, that sympathetic system is lost. So let's cross that off, and the only system in play is the parasympathetic, and the parasympathetic does the opposite of the sympathetic. So instead of vasoconstriction, you'll have vasodilation. Instead of high blood sugars, you'll have lower blood sugars. Instead of sweaty skin, you'll have dry skin. So a patient with neurogenic shock tends to have a low blood pressure due to vasodilation, their blood sugars don't elevate, and they have the dry skin. Now let's go back again and look at other receptors. Remember, you also have beta-1 receptors in your body. These are stimulated by the sympathetic nervous system, and they're found in your heart. And they cause things such as elevated heart rate, increased automaticity, increased contractility when they're stimulated. Well, remember, in a spinal cord injury, you've lost your sympathetic tone. So those are lost, and the patient can no longer do those things. So the parasympathetic is the only system in play, and it does the opposite of the sympathetic. So we'd expect a patient with a spinal cord injury to have a decreased heart rate, decreased automaticity, decreased contractility, all due to parasympathetic stimulation. You also have beta-2 receptors associated with your sympathetic nervous system, and they increase the respiratory rate and cause bronchodilation. So in a spinal cord injury, those are lost. Instead, the parasympathetic takes over and causes a decreased respiratory rate and a bronchoconstriction. So neurogenic shock is just pure parasympathetic stimulation of your patient. And that's going to cause things like vasodilation, decreased heart rate, decreased respiratory rate, dry skin. If you've watched the module on this series already on hypovolemic shock, you'll remember that hypovolemic shock is caused by sympathetic stimulation. Neurogenic shock is caused by parasympathetic stimulation. So these two shocks are almost the opposite of one another. And neurogenic shock can have profound effects on our spinal cord injured patients. So it's important to recognize the presence of neurogenic shock and treat it. So that we've already talked about the symptoms of neurogenic shock: hypotension, dry skin, bradycardia, decreased respiratory rates. What's the treatment? Well, for the vasodilation, fluids is the treatment. And surprisingly, most patients with neurogenic shock who vasodilate will respond to a couple liters of fluid. Unless they're bleeding from some other injury due to their trauma, the vasodilation of spinal cord injury usually responds well to a couple liters of fluid. Give them 1 to 2 liters of isotonic crystalloids. That'll fill the dilated bed, bring their pressure back to normal, and for the most part, that's all that's required. You have to be careful. You don't want to keep giving fluids to these patients because, remember, unless they're bleeding, they're not losing fluid, they're just dilated, and the extra fluids in the system can drive heart failure. So if a patient with neurogenic shock and a low blood pressure doesn't respond to a liter or 2 of fluid, instead of continuing to give fluids, we then move on to alpha agonists. phenylnephrine or neosynephrine being the main drug of choice here. Neosynephrine is a pure alpha agonist. It causes vasoconstriction of the blood vessels and helps to elevate the blood pressure if 1 to 2 liters of fluid doesn't work. And that would be preferred over continuing to dump fluids into somebody who's a pure neurogenic shock. Now, for the decreased heart rate, well, before I get into that, just to mention for your patient with hypotension, what you do have to remember is that these patients often have other injuries. They may have a liver lac or some other bleeding injury, and that can exacerbate their hypotension. So they may be hypotensive from vasodilation due to parasympathetic stimulation and hypotension to blood loss. So you could have, several causes of hypotension. And the problem is that if the patient's also bleeding, let's say they have a liver lac and they're bleeding, you can give them additional fluids for the blood loss, but you're never going to bring their blood pressure back to normal if they also have a spinal cord injury because of the vasodilation of neurogenic shock. So blood pressure and pulse are inadequate indicators of fluid resuscitation in the hypovolemic patient with a spinal cord injury. And in these patients, it can be tricky because you can give them a couple liters of fluid or give them some blood, but their blood pressure and pulse won't rise because they also have neurogenic shock. And so how do you know when you've adequately resuscitated them? Well, you have to look at other indicators, including serum lactate levels and arterial blood pH, serum pH, to determine if your patient is perfusing at the cellular level because their blood pressure won't normalize with neurogenic shock. Now, moving on to beta-1 stimulation, or lack of it, in the parasympathetic system, if you have beta-1 stimulation on the parasympathetic side, your heart rate, automaticity, and contractility are going to decrease. How do we treat this? We may need atropine. Atropine may be used to elevate the heart rate in a patient with severe neurogenic shock. Now remember, if the patient has both a blood pressure and a heart rate problem, then dopamine, norepinephrine, or epinephrine may be used to elevate both the heart rate and the blood pressure in neurogenic shock. And for people with really high cervical spinal cord injuries, they may have difficulty with their heart rate for the rest of their lives and may have to have a pacemaker inserted. I want to make sure I mention that there's a difference between spinal shock and neurogenic shock. We've just talked about neurogenic shock. It's a loss of sympathetic tone from the level of the injury down. Now, one thing I didn't mention earlier and I want to mention now is that neurogenic shock, that loss of sympathetic tone, requires a pretty high spinal cord injury. If you injure your spinal cord really low down, there'll be enough sympathetic fibers exiting out to the body above it that you won't have neurogenic shock. But if you have a really high spinal cord injury, you'll lose enough sympathetic tone that you could develop neurogenic shock. Generally, neurogenic shock only develops in injuries above T4 to T6. And these patients will come in with loss of sympathetic tone. So they'll be vasodilated, dry skin, low heart rate, low respiratory rate. That's neurogenic shock. Now, sometimes you'll hear people use neurogenic and spinal shock interchangeably. Don't. They are not the same thing. Neurogenic shock, loss of sympathetic tone for injuries above T4 to T6. Spinal shock is a concussion to your spinal cord. If you shake up your spinal cord, it may not transmit nerve impulses correctly, at least for a period of time, which means that the area below the concussion or below the spinal shock will have loss of movement and sensation. So the patient may come in and look like they're a complete spinal cord injury, but actually the spinal cord is not injured, it's a spinal shock, and there could be loss of that motor and sensory function below the level of the injury that the patient will regain. As the concussion clears, the impulses will begin to move again and the patient will regain their movement and their sensation. Now it can take as little as 5 minutes for spinal shock to clear, but it can take as long as 72 hours. One of the reasons in the emergency department we don't discuss how permanent a patient's spinal cord injury is we don't know how much of their deficits are actual spinal cord injury and how much are spinal shock. Some patients may have complete spinal shock. They can come in as though they were paralyzed from a certain area of the body down, and then an hour, 2 hours, a day, or 2 days later, they completely regain that function if they were a complete spinal shock. Many times, though, patients with partial cord injuries will have a partial cord injury with spinal shock. So they'll come in and they'll look like they're a complete cord injury because they have no movement or sensation below the level of the injury. And then, over the next hours or days as the spinal shock clears, the function returns to the part of the spinal cord that's not injured, and they may regain some of their movement or sensation. So we really don't know for at least 72 hours how permanent a patient's spinal cord injury is, because it's impossible to know how much of their deficits is related to spinal shock and how much is related to actual injury. But the thing I want you to take home from this slide is to differentiate between neurogenic shock, loss of sympathetic tone from high spinal cord injuries, and spinal shock, a concussion to the spinal cord with temporary loss of movement and or sensation below the level of the injury. Another thing to consider with spinal cord injuries is something known as poikelothermy. It's a fun word to say. Try saying it, poikelothermy. Poikelothermy is assuming room temperature. Because patients who with spinal cord injuries develop neurogenic shock, they vasodilate, and they then tend to take on the temperature of the environment around them. Some of their heat will be lost into the environment from evaporative losses, and they'll also assume the temperature of the room. Now, of course, room temperature is much lower than body temperature. Body temperature is what, about 97 Fahrenheit? Room temperature is 70 Fahrenheit. So there's almost a 30-degree difference between room temperature and body temperature. And if you vasodilate due to neurogenic shock, you will begin to assume room temperature and become chilled. And chilled trauma patients are at risk for coagulopathies. I want to get into a controversial area here to bring this to a close and talk about neuroprotection. Neuroprotection is the delivery of drugs which are believed to minimize secondary insult to the spinal cord. We talked about secondary injury earlier. There's a number of different drugs that have been studied over the years. I've listed some on the screen. And I'm just going to say that not a single one of these has been shown to improve function after a spinal cord injury. Therefore, none of them at this point are standard of care at the point of this taping. And if they are given experimental or given outside of standard of care. None of these are considered neuroprotective in any way. There's no research to indicate that the neuroprotection occurs with any of these drugs. I think the one I want to focus the most on is Solu-Medrol or methylprednisolone. Some of you may still give it. I assume a lot of you no longer do. And it's very controversial whether it's given or not. So I thought I'd take a minute and talk about the controversies surrounding Solu-Medrol. The use of Solu-Medrol for spinal cord injuries comes from the NAXIS studies. NAXIS stands for National Acute Spinal Cord Injury Study, done in the 70s and 80s. As you can see on the screen, in the initial NAXIS studies, patients were given either a 1,000 milligram bolus of methylprednisolone followed by 250 milligram infusion Q6 for 10 days, or a 100 milligram bolus followed by a 250 milligram bolus Q6 hours for 10 days. The bottom line is, in those first two studies, there was no improvement in neurological function after the administration of methylprednisolone, and therefore methylprednisolone was not used in spinal cord injuries at that time. In 1990, they repeated the NAXIS study a third time with a different dose. And you can see the dose listed on your screen there. It's 30 milligrams per kilogram, followed by a 5.4 milligram per kilogram per hour dose over 24 hours. Many of you will recognize this. This is the dose of methylprednisolone that we've used for spinal cord injuries for years. I want to tell you a little bit about how this unfolded. The NAXIS study was undertaken, and after giving methylprednisolone at this dose to several patients, they noticed that these patients had an improvement in spinal cord function and neurological function. Now you got to remember that this occurred back in 1990, long before the days of internet. So as researchers noticed that, wow, when we give these high doses of prednisone, the patient improves, they decided they better tell the world, because they had just found the first intervention that actually works for spinal cord injuries. So they called a huge press conference. They announced their findings to the world. Now, fax machines were in use at the time, so they faxed these early preliminary results to hospitals and doctors' offices. They even put out press releases, and guess what? It caught on like wildfire. People for the first time thought that they had found a treatment that would help reduce the deficits of spinal cord injuries, and most hospitals and doctors immediately adopted high-dose methylprednisolone as the treatment for spinal cord injury, and it became standard of care. Now, if we go back and look at the Nexus study, we find that it wasn't as scientific or accurate as what those initial press releases made it. Let's look a little bit at the study. Was that study prospective? Now, if you've forgotten what prospective means that it follows patients through after the initial study. So in other words, in this case, they gave the patient methylprednisolone. They assessed whether or not there was an improvement in function. If there was an improvement in function, then they reported it, but they didn't follow the patient to see if that improvement was sustained over a longer period of time. So was this study prospective? Did it follow these patients through? You probably know the answer by now. It is no. Was the study randomized? No, it was not randomized. In other words, researchers chose who would get methylprednisolone and who would get the placebo. Can you see any chance for researcher bias here when you're giving certain patients the drug and others not? I mean, that completely destroys the scientific basis for this study. Was the study blinded? The answer is no. It was clearly labeled whether the patient was getting Solu-Medrol or whether the patient was getting a placebo. And remember, when they were assessing whether the patient had improvement in neurological function after the drug, there was some subjectivity to it. You know, they were asking the patient to carry out certain things which are subjective. Well, if everybody know whether there was a placebo or a drug being given, there is the opportunity for researcher bias. Would this study stand today if it were published? Absolutely not. It was not a scientifically sound study. It was not prospective. It was not randomized. It was not blinded. But there's some other disturbing facts about the Nexus studies. There was a very low number of subjects. In fact, you ready for this? Guess how many people were enrolled in the Nexus study on which we based methylprednisolone for years? 129 patients. That is hardly statistically significant, yet we've based all care on that very small number of patients. A few other interesting facts about the study. Did you know that the doses chosen were not scientifically chosen? They were just randomly chosen. They just gave patients this amount of Solu-Medrol and it worked, and then they didn't test to see if lower doses might be more effective or higher doses might be more effective. They just used that dose. But here you go. The most telling part of this study came to the fact that when you go back and read the results of the study after it was published, not the preliminary results, but after it was published, there was statistically no improvement in outcome for those who received Solu-Medrol versus those who received placebo. So those early preliminary results did not stand up when the study was finished. And there is absolutely no evidence to demonstrate that methylprednisolone or Solu-Medrol improves neurological functions overall in patients with spinal cord injuries. I want to give you a very quick theory, and I think that's one thing that's important to stress on this slide is this is a theory. It is not proven, but I think it's interesting. That's why I bring it up. Did you know that high-dose steroids can stun the neurological system and cause it to be less responsive? So think about this. You have a patient with a spinal cord injury, you blast them with this large dose of steroids, and that stuns the neurological system and may lead to some deficits. Then, 24, 48 hours later, the steroids wear off, the deficits resolve. What does it look like? It looks like the patient improved. And they chalked the improvements up to the Solu-Medrol when in fact the Solu-Medrol may have been the cause of the deficits in the first place. Just a theory, but an interesting thought, is it not? Now, what I do want to focus on here for a minute is what was not reported in the initial press conference about Solu-Medrol. This was only available at the final report, and these were not well published. But what was not reported in patients who received Solu-Medrol in the Nexus study, they had 3 times higher rate of developing a pulmonary emboli than those who got the placebo. They had twice the rate of wound infection, 1.5 the times of GI hemorrhage, double the chance of severe sepsis, and 4 times the risk of pneumonia. So there was no evidence to indicate that Solu-Medrol improved outcome, but there was lots of evidence to indicate that high-dose Solu-Medrol led to a significant amount of other complications, which was not well reported. So where are we on methylprednisolone or Solu-Medrol today? Well, the Consortium for Spinal Cord Medicine, which I referred to earlier in this presentation, has made a final ruling, and here's what they say. There is no clinical evidence to definitively recommend the use of any neuroprotective pharmacological agent, including steroids, in the treatment of spinal cord injury to improve functional recovery. That is right. Methylprednisolone is basically contraindicated. It is not part of the standards of care for spinal cord injured patients. Did you know the FDA never even approved methylprednisolone for the treatment of spinal cord injuries? Anytime methylprednisolone was given to patients for these injuries, it was given as an off-label use. Now, there may be some of you out there who still use Solu-Medrol today, or your physician still order it. All I can say is that it is no longer the standard of care. And when interviewed, the question was asked, why do some physicians still use Solu-Medrol? 70% of spinal surgeons stated that they know that methylprednisolone does not work. The studies are clear that it does not work. However, they continue to use it only because there's no alternative. When we remove methylprednisolone, we've not replaced it with anything, and so they feel safer doing something than nothing. I'm going to leave one challenge with you, though. Now that we've clearly laid out that there is all the complications associated with the use of Solu-Medrol, is there not an increased risk of lawsuits if the patient were to develop pneumonia or sepsis, been given Solu-Medrol, and they die? Would there not be an increased risk of lawsuit by using it rather than not using it, since it's known not to improve things but known to worsen things? And I just leave you that thought. So I hope that this gives you some food for thought as you care for your spinal cord injured patients, how to assess them, how to care for them, and where the current standards are. Thank you very much for your attention, and I hope you learned something.